Good afternoon, everybody. Welcome. I think we've got one person with their camera on. Awesome. I do love to see the teamless face of Teams, or the faceless face of Teams, whatever the right phrase is for that. But thank you very much to the person who's currently sitting there with their camera on. I'll wave hello to you because that's the only person I can see apart from the other speakers, and Lauren, who's helping me out with the admin today. Oh, there we go. Look, someone else feels sorry for me. So we've now got two people with cameras on. So welcome to this. We've put this session together very quickly, so we are aware that we haven't given much notice for this. However, that doesn't seem to have stopped the interest in it, because we have never had so many people register. We've got over 200 people that have registered for this talk. So I think it shows you the level of interest in the area. So for those of you who've never attended one of these sessions before, my name's Jo. It's Jo Howe. Sounds a bit like James, doesn't it? James Bond, except I cannot relate to anything on 007 levels. But I run the Mental Health Innovation and Improvement Network. And part of that is it's arisen from my own research in physical health in SMI. And so we're always interested in running talks on areas that are connected to the physical health of people living with severe mental illness. And this came out, this particular module session has been put together very quickly based on some concerns around implementation of the new WIMS protocol, which we're going to go into in a moment. So Lauren, I think, is going to put in the chat for us, and I will try and click on admit in the lobby. Some information on where you can find out more about the network. So if you want to join future talks, you need to join our JISC mail list. All of our talks are recorded and they're all stored on a YouTube channel, and they are all free to access. You just have to cope with the YouTube adverts, but you can access them at the moment forever. So help yourself over to that. If people are joining, just put your mics on mute, because I cannot cope with talking whilst other people are talking in the background, because I don't have that much brain capacity. So Lauren hopefully has done that. We've got the sign up to the JISC mail and the YouTube channel, and we'll put that in again for people who are joining through this talk. If your internet drops out, just try and rejoin, but if not, give us about a week and this talk will be on the YouTube channel for you to go and review afterwards. So without further ado, then I'm going to very quickly try and hand over to our two esteemed guests for today. So we've got Doctors Ed Beveridge and Claire Jones, who've come over from the Royal College of Psychiatry to help us facilitate this session. Now, Ed is one of the most accomplished people that I think I've ever met, and the bio that we've got from him goes on for about 10 years. So I'm just going to give you a very quick potted history about Ed. So Ed's from London, and I think we can all make our own viewpoints on London, especially as I'm from the north of the northeast. And he trained over at Oxford, and then took psychiatric training in North London, and until, let me find this bit, until June 2026, so just last month, Ed was the presidential lead for the physical health at the Royal College of Psychiatrists. And that is, you've been heavily involved. I think you've been leading this, haven't you, this protocol, Ed, which is why we've invited Ed. Then Claire works with Ed, and Claire and I have been working together for about a year and a bit on a couple of related projects around physical health and severe mental illness. But Claire is an ST6 trainee in general adult psychiatry, working also in Southwest London. So we've got a heavy London presence here. So Claire is one of the current physical health scholars over at the Royal College of Psychiatrists, and she's had a very varied career pathway to becoming a psychiatrist that I didn't find out until she was doing a talk for me. I think it was last September, because Claire used to be an anaesthetist, which I found fascinating. Anyway, so Claire has developed an interest into how she can work with teams to improve the physical health of patients. And she's using her time as a physical health scholar to contribute to projects, including writing a physical health position statement for the Royal College that I've just heard about a few seconds ago that might have a new name or a new title to it. And also her ongoing work is going to be looking at preventing antipsychotic weight gain and input into the development of guidelines for treatment with clozapine, which is this particular focus of this seminar. So I'm going to quieten now and hand over to you two. We're going to have a series of Q&A where we've collected some of the people have emailed me directly, and we have a whole list of questions that Claire will ask, and between the two of them, both Claire and Ed will answer them. If you have other questions that you need to be answered, please put them in the chat. If we get time at the end of this, we will start to work through them. And if not, we'll pass them all on. And I think, Ed, you said you were going to try and do an FAQs for the Royal College. So we'll be able to, if you join the network, we'll be able to let you know how you can access that FAQ as well. So unless you two want to mention anything else or say anything else, I'm going to stop waffling and then we can get going.
Right.
Thank you, Joe. Very excited to be here. So hi, everybody. It's my second visit. I think it's yours as well, Claire, isn't it, to the network?
It is. Yep. Welcome.
So what we thought we'd do is I will tell you a bit about the protocol, and I'll actually show you the document on the screen. I realise that some people may know it quite well. Lots of you by the look of it. Absolutely incredible numbers of questions and interest. So we're really, really pleased to see that. So what I'll do is I won't presume everyone knows all about it. I will tell you a bit about how it developed, what it's for, and what the document looks like. And then Claire is going to, Claire as editor of the CPD podcast at the Royal College. Is that right, Claire?
That is correct. Yep, Ed.
Yeah, so she's going to use our best podcasting skills to do a Q&A, which hopefully will pick up quite a lot of what you've already fed back, which is great. But it's lovely to be here. I'm north of the river. Claire, I think, is south of the river. So there is a bit of geographical variation, despite it all being quite London. The person who's not here is Mao Fong Lim, who
I'm
is
here.
another. Oh, are you, Mao? Where are you?
Hello, I'm here.
Oh,
I'm
my
not sure if I
goodness.
can stay for the whole thing, or I wasn't sure if I could make it, but hi, I'm here as well.
Brilliant. Well, you can answer all the questions then. Thank goodness for that. Sorry, Mao, I didn't realise you were joining us. So, Mao, do you want to introduce yourself?
Yes, I'll do a brief intro. My name is Mao. I'm a psychiatry registrar based in Cambridge, and I was one of the physical health scholars alongside Claire as well. And I was the lead author for the clozapine protocol with Ed and Claire's wonderful support. And Claire's done a huge amount of work on this as well. So I'm glad we're all here, and hopefully we can collectively answer your questions and concerns about implementation as well. Thank you.
You'll probably do a better job than either of us with most of them, Mao. So I will be chucking a lot of questions your way. Okay,
I'll try.
Brilliant. So you have the full team pretty much. So how did the protocol come about? So some of you may know the backstory, some of you may not. Some of you may not know who Wim was. Wim was William Northcott, and he is a man who had a long-term psychotic illness and a number of other mental health issues, who died suddenly in his 30s in the context of taking clozapine. And in his post-mortem and in the inquest that followed, there were a number of things about his clozapine treatment which likely contributed to his early death. And some of those might well have been mitigated or prevented by more robust monitoring of his physical health, his clozapine levels, and various other things. And Wim's sister, Kate Northcott Spall, was determined that this shouldn't happen to people in the future. And the first time it came onto my radar was in, I think, 2023, when there were some quite strongly written articles about Britain's most lethal drug, or words to that effect. So there was publicity in the Times and other newspapers about how clozapine is dangerous and, raising a lot of concern about it. That was partly stemming from Wim's story, but actually not just Wim's story, because we know that there have been other deaths under related circumstances. And the reason we knew this was because we were getting feedback through the coroner's court. So the Royal College of Psychiatrists was being included in what we call PFD reports, prevention of future death reports, issued by coroners when they have a concern about something that could result in a preventable death and that action should be taken. So it became clear that there was actually quite a level of concern in the public and in parts of the country about the safety of clozapine and how effectively we were monitoring for causes of preventable death. In the background, our former president, Laddie Smith, she finished her term last month, had engaged with Kate, Wim's sister, trying to work together to think about what outcomes she and the college could achieve in terms of preventing things happening to people in future, as happened to her brother. And one of her ideas was that there should be a protocol for monitoring for not just white blood cell counts, because we do that very well already, and increasingly it looks like that's actually quite a limited cause for concern about safety, but for the other things which do lead to preventable deaths. And Kate has worked with us as the Royal College for the past couple of years, and this is the output. It's not just a clinical guideline, it's also supposed to be a choice tool. We wanted from the outset for this to be something that patients, families, the network around patients could use as part of the conversation around clozapine. Bearing in mind that most people that a patient on clozapine sees today are not doctors and are not nurses, but they'll be family members, friends, support workers, and so on. And so we wanted to make something that was of use to all of those people. And we generated it by a combination of different techniques. So we did extensive, Mao and Claire, did some extensive reviews of evidence, looked at what the expert consensus was, looked at different places' guidelines, and consulted a number of individuals and organizations with expertise in the area. Because it's clear that in some areas there isn't a clear answer in the evidence about what the right thing to do is. There are either competing views or the evidence doesn't point you in a clear direction. So what we've come to is we think the best consensus, using the experts that we had available to us, who were many, to come up with what we think is the most pragmatic output, the most pragmatic set of guidelines that we could, acknowledging that if you look across the country, different places, everywhere has its own clozapine guidance, protocol, processes, and they're all very different from one another. So what we wanted to bring was something that actually gave a consistent set of standards and messaging that could be used across the country. Quite evidently, different areas vary in the resource they have and what's available. So not all areas will be able to deliver all of the protocol. We understand that, we acknowledge it early on. So I suppose that's an important thing to say, that one worry that people have had is there's stuff in here that we just won't be able to do. We know that, but but I guess it's what we think of as an aspirational standard to get to. We triangulated the work with an audit done by the Prescribing Observatory for Mental Health, which is another part of the Royal College of Psychiatrists, and they did a really detailed clozapine audit in the last couple of years. And what we were able to do was sense check whether the things we were saying people needed to do were actually doable. And we found that pretty much all of it was. There were places that were doing all of the things that are in the protocol. Most places were doing some of them. Some places were doing very few. But we did try and sense check with what is custom and practice across the country. And we think that we've come to something that should be deliverable or mostly deliverable in most places. But this is version number 1. And we are very keen to develop the next version on the basis of people's feedback, including things like special patient groups, children and young people, people with learning disability, older adults, and so on, which don't come in the current version, but we think that we would be able to develop material for moving on. So one of the brilliant things about having all of this feedback from people is that we will be able to. People just pop themselves on mute. That would be great. So one of the brilliant things about a session like this, the feedback that we've had, is that we will be able to use it in real time to develop the end product. And as Joe said, I think we'll do some FAQs for the Royal College website, also based on feedback that we've had. I'm just going to share my screen and look at the document. We can have a look at the document together. I'll try not to break Teams if I possibly avoid it. So some of you will have seen this already. Some of you may not have done. So this is what the protocol looks like. And I'm just going to, hopefully not making you seasick, I'm going to scroll through and just talk you through the structure of the document. And so you can, those of you who aren't so familiar with it can see it. So it's an unusual kind of Royal College publication, a practical guide. There are certain kinds of publication like a position statement or a college report that we do quite commonly. This is a bit unusual for us to do something like this. Just going fairly quickly through the beginning. So there's a foreword by Kate, who I mentioned, about WIM. And there's one by Laddie Smith, the president, as I've already said. I'll scroll through this. Please, apologies for the rapid text passing. I will try and not do that too much. So I guess we intended for this to be read by anyone who's interested in clozapine, be that a professional, be that a doctor, a pharmacist, a nurse, but also a family member who is interested in knowing more, which most family members tend to be, and we're not very good at giving them that kind of information. So we go through why we think the protocol is needed, and then we are quite specific about what's in there. So physical health monitoring in detail, minimum standards, we think, for investigations and interventions, but actually I think that for some places they might be hard to reach as minimum standards, and that's absolutely fine. We've talked about some red flag symptoms. I'll say more in a tick. We've given some escalation guidance around those symptoms, both for patients and carers and for healthcare professionals. We don't talk about certain things. So we don't talk about who's suitable for clozapine, partly because there's a position statement that the Royal College has already produced about that. We don't talk about continuation re-challenge. You know, that's not really in the scope of the document. As I said, we haven't covered every specific patient group, and we haven't given detailed management about how to manage comorbid physical health conditions. We've given some very light touch sort of escalation guidance around what to do with certain red flag symptoms, but really the idea is for people to know what they need to get senior or expert help on. So you'll see there's some introductory material. We go through some potentially serious adverse effects of clozapine. This is very much rooted in what happened with Kate and what happened with other people who have died in the context of taking clozapine, and it's nothing to do with their blood cells. So myocarditis early on, severe constipation, which we know is a big problem and does come up in prevention of future death reports. Infections, blood clots, cardiomyopathy, which is more long-term damage to the heart muscle and consequent heart failure, and the effects of sedation as well as seizures and fits. So we have put these together into a set of tables. So you should now be able to see the red flag symptoms, and I'll just explain how what the logic is behind doing this. So what we want to do is for people who are taking clozapine, are caring for someone who is taking clozapine, or are seeing them day to day, is to understand that if they develop a particular symptom, it might be concerning. And we've tried to put an escalation process in place where you have a symptom, but it's not urgent, and you just need to talk to your clozapine clinic about it next time, and there's some advice for it. There's things that may be needing more urgent attention, and we advise to seek medical advice within 24 to 48 hours. And there's things where you need medical help now. And we've been very, I think, we try to keep it as simple as possible. So we consulted with NHS 111 about what the advice should be in the 4 nations of the UK for people to seek help, because we were originally saying go to emergency department, but actually 111 is the route into all of the urgent and emergency care. So we tried to keep that very simple. So you can see constipation in front of you. You can see that on the left, if you've not opened your bowels for 48 hours, there's some conservative advice. If you're getting towards 72 hours, then that's more concerning. If you're over 72 hours, we think that's something you need medical help for. Now, some people may raise eyebrows at that, and I'll say a bit more about the bit for healthcare professionals. But actually, if you're seeing deaths from severe constipation, we need to do more about it than we already do. And I won't go through all of these, but you can see that for each of those red flag symptoms, we've come up with a similar set of advice. Some of them, as you'll see, are just seek urgent help, like shortness of breath or chest pain, because you should never sit on those till your next appointment. So coming to this appendix, while we're about it, we consulted with a number of different medical specialties, so particularly Royal College of Emergency Medicine, but also GPs and others, because one of the other issues is that there's not that much awareness of some of the risks of clozapine in the wider system. So we weren't assured, for example, that if one of our patients on clozapine turned up to the emergency department saying, I haven't opened my bowels for a week, that they wouldn't get told to go home, that we weren't assured that everybody who that patient comes into contact with outside of mental health would understand the need to act more assertively about certain things like constipation and shortness of breath. So we provided some more clinical advice, done in the same style, although with different content, for people who are other health professionals coming into contact with our patients on clozapine. So you'll see, for example, for the constipation, the kind of advice is different, but it gives you flags about what symptoms are concerning and what might need an urgent or emergency response. And it's similar but not identical to the patient and carer red flags, because it's designed for healthcare professionals, so it's in more clinical language. So moving on, I'm just going to walk us through the monitoring guidance, and I think there are a lot of questions about that, so I won't spend too long on it. But I suppose firstly we try to recognise who's going to be prescribing and where, and trying to delineate responsibility, which we can't do in detail because it does really vary from area to area. We've given you some terms because some of the tests are not that familiar, troponin and pro-BNP in particular, and I know there were some questions about that. So that's the glossary. And then we've tried to think about an end-to-end process from the first time people are thinking about clozapine to when someone's been on it for years. All of the stages in that process, what are the risks at those stages, and what do we need to be doing on a regular basis? So we've given you baseline measurements, and we've given you different phases. So we've come up with what should you do in the first 4 weeks that we called the titration phase. One of the things we were trying to do is simplify it. So there are some things you should do for the first 6 weeks, or the first 8 weeks, or the first 4. So we've tried to chunk things up into as small a number of stages as possible. So you've got your titration phase, you've got your next 4 weeks, which we've called stabilization. We talk about target doses during that time. We talk about early maintenance, which is your weekly blood test period, if you like. We talk about longer term maintenance, which is your 2 weekly blood test period, if you wish. And then we talk about at the end of 12 months and then every 12, what happens during your year on clozapine in your maintenance period, as it were. And again, we've put we're trying to future-proof this, because it's quite likely at some point, I think, that monthly monitoring will disappear for some patients. I think as genetic testing becomes more prevalent, we might lose a lot of the blood monitoring altogether, which is great in one way, but we also lose the monthly touch point with people, and that's where we're going to pick up some of the red flag symptoms. So we thought it was really important actually to think about, what do we imagine someone was on 3 monthly bloods? How would we continue to assure ourselves that they were not at risk of developing something more serious? I'm going to stop sharing there, because actually that's the main walk through the protocol. I don't know, Claire or Mel, if there's anything you wanted to add about that I've missed out, or that we could think about at this point.
I suppose probably not at the moment. I think there's quite a few questions that I've got that might cover things in a bit more detail, but I don't know, Mao, if you've got anything.
No, nothing to add at the moment. And thanks, Ed, for going through the protocol.
So Claire is going to quiz both of us, and I'm as I say, very delighted that you are here, Mal, because I think I'm going to pass all the difficult ones on to you, basically. But let's see how we get on. But yeah, Claire, do you want to kick us off?
Yeah, thanks. I mean, I think thanks very much, Ed. I think that's a very comprehensive introduction. I was going to start off by asking about sort of variations in local resources and infrastructure, but I think you probably covered that at the beginning. But I suppose we know the NHS isn't homogenous, and if there are colleagues who are working in perhaps tertiary centres compared to sort of very much more rural areas, there's a question about where and what should people prioritize for sort of full implementation as a priority sort of point of view. I don't know if we can even answer that really, because it's quite a general question.
Yeah, I mean, I suppose my view on this is that yes, we know from the POMH audit that we have quite variable practice, but as I say, some of it's quite comprehensive. And we know that different parts of the country both have different levels of resource, but also have quite different geography. So if you're living in a really rural area, there's a limit to the number of appointments you can go to, and you might have to do more in fewer appointments, as it were. You know, you might be in hospital, in which case there's loads of access to do a lot of different tests if you need them. But if you're having a home-based clozapine titration, then you won't be able to have daily OBS, and that's fine. Part of what we want to do is drive consistency, but also give people a bit of support when they're having conversations about resource. Because actually, if you can't get good access to ECGs, I would say that's a problem that someone needs to help you with, and that then you can this sort of resource gives you some backup to say, actually, we need to do this better for our clozapine patients, and we need a bit more resource to do that. But I realize resource is very thin. But I think it might be something that helps clinicians have conversations about safety and quality that they're struggling to have so far. The other thing to say is, this isn't regulations. You know, we're not the regulator, and we, you know, this is guidance. And our hope is that as people start to adopt it, we'll get more consistency over time, and we'll learn more and more about what works and what doesn't in different kinds of locations. So future versions will be able to pick that up. So I suppose that would be my thoughts about that.
Great, thank you. And I think that probably leads on to, I think, one of our most frequently asked questions that I've already seen something about in the chat is about the availability of troponin I versus troponin T. And are we suggesting that's the only troponin to be doing? Then thinking about, is it going to increase costs of going to specialist laboratories and things? So I don't know what your thoughts are on that.
I'm going to see what Mal thinks, but then I do have an answer myself. So don't worry, I'm not completely passing about. But Mal, do you want to come in on that?
Yeah. So just jogging my memory as well, and trying to juggle clinical demands today. But I think I haven't looked at the cost aspect, and Ed, you might have a better idea of this as well. But what we saw in terms of when we were looking into this was that in most places, troponin I is sort of the cardiac specific one, but it's also the high sensitivity one has now become standard. But I'm happy to be corrected on that if that is actually not the case. Ed, what were your thoughts on this?
So yes to high sensitivity. So there's high sensitivity troponin I and high sensitivity troponin T. We went for I because that's what colleagues from, if I remember correctly, the Maudsley said was their preferred option. However, it's actually T is fine for this purpose as well. So if you only have high sensitivity troponin T, not the easiest thing to say. So hopefully there's an abbreviation. If that's all there is in your local lab, that's absolutely fine. Cost-wise, they're usually between 5 and 15 quid. I looked at BMP and I looked at troponin. They're not hugely expensive tests. The other thing is that contracts vary. So one mental health trust, for example, might not have troponin T in their contract for regular blood. So they might have to buy it as a spot purchase, which means that it might be more expensive. And that could be a conversation that you have locally with your provider. But I think high sensitivity I or T are good enough. This is to detect myocarditis, which happens in the first 6 weeks generally. It doesn't frequently happen after that. So that's the reason for going for troponin. Mal, did you want to come back?
Yeah, and just to add as well, that bit of the guidance was based off this consensus paper that I've put in the chat. And in their paper, they do specify high sensitivity, but they actually do say that I or T is fine for this purpose as well.
Yeah.
Yeah.
So that sounds like an FAQ that we can certainly highlight the answer to for sure.
Because I think that has been that's been super popular question that we have had, and I think that links us on to then thinking about linking in with sort of laboratory services, clinical scientists, the impact of them, and have they been or were they involved in the protocol and the development of this?
A good question, not directly, and I think it's a really interesting example of how stuff varies between different places, because the way, so in my day job, I'm a manager in an NHS trust, and actually the more you get to know how contracting works, the more you realize that everyone does it very differently. So you will have a contract with a person who does your tests, but what tests are in the contract and at what price will really vary, and labs vary in what they do. So as we've seen, some places do troponin T but not troponin I. So I guess my advice or my thought about this issue is that it's something probably to discuss locally with whoever arranges your pathology. So if, for example, you can't get BNP or troponin, that will be a conversation with the organization to see what they can do about that, because these are fairly routinely available tests, I would say. So I would say discuss locally with your clinical leadership if you are not sure about the availability of tests, or if you're not getting the support you need from your local laboratory provider, as it were.
Great, thank you. I suppose thinking also, one of the things we have focused on more that more than has been done in the past is ECG monitoring. And we know that the availability of that and the interpretation of that across different services can be quite variable. I think, Ed, you did touch on it briefly in sort of your introduction, but there is the potential for this to substantially increase workload, and also patients getting annoyed with it, not wanting it. Where do you sit with that?
Well, I'm gonna give the frequency question, I think, to Mal, because one of the so it's an area where the evidence is not, it doesn't really give you a very clear answer whether you should have yearly or 6 monthly, and we recommend it more frequently in the beginning, and that's again something that has been raised as a concern. The answer is, do them as often as is feasible in your area. So if it's really, really difficult to get, say, weekly ECGs, as I think we recommend early on, I would be making a judgment around the person's clinical state, really, because there are some people who have no cardiac history, very low levels of other risk factors, who are just at much lower risk of the sorts of things you need to detect via ECGs. There are some people, so someone who might have a baseline high QTC, for example, or someone with a history of cardiac illness, it's important to do more frequent ECG monitoring for them. So I think probably my advice would be, if what's in the protocol is difficult to achieve, then think about what the clinical needs of the patient are. And are you dealing with somebody who's young, fit, no cardiac history, no family history, no problems tolerating antipsychotics? That's a very different patient from someone who is older, has cardiovascular risk factors, has a cardiac history, has a prolonged QTC interval, that sort of thing. So I guess people can use their clinical judgment for that. And again, I guess it's also an opportunity to put pressure on your organizations to make sure you do have access to ECG equipment and ways of reading them, because I think it's incumbent on organizations to give their clinical teams what they need to prescribe safely. But I don't know if you had more thoughts about that, Mal, particularly around the frequency.
Yeah, I guess to comment on the frequency at the start, that was again guided by the Wagner paper that I put in the chat. And yeah, with what Ed said as well, it is well, I guess we are suggesting this based on sort of suggestions from the consensus as well, but we recognize that there can be constraints about how frequently it can be done. Yeah, I just wanted to add the point about where it comes from, really.
Yeah, and it's a good example of where. So I think standard custom and practice is usually an annual ECG for anyone on a mood stable or antipsychotic. That's what's generally done. So building on that, you can probably very reasonably say once a year is minimum. But because clozapine has some particular additional side effects that we've already discussed a little bit, it does make an argument that more frequent monitoring is probably helpful where it's feasible and where it's clinically indicated. But the 6-month ECG is not a hill I'm going to die on.
I suppose that also links us in quite nicely. There were some questions about cardiology advice and thinking about the support from cardiology and the variations across different services, different links between mental health and cardiology. Possibly if we're doing more testing, coming up with sort of borderline or marginal results, increasing our need for cardiology advice, and how do we either improve relationships or foster the support that is needed?
It's a really good point, and I think it's for as long as I've been doing this work, it's been contentious in some areas. What if we get an abnormal ECG? Do we have access to referrals for cardiology reviews? Can we, again, do we have a contract that enables us to phone someone up and ask them questions? I suppose cardiac risk is probably not something we've been brilliant at detecting, and something that we definitely wanted to do better. But it's also something where the evidence is does point us in a bit of a different direction from some of the usual practice and guidelines that people have, particularly around some of the blood tests. So we talked about troponin and also BNP. It's one of the areas where we had to do quite a lot of consulting, and we got a lot of support from the British Heart Foundation, who put us in touch with various people, including an expert in cardiomyopathy, who was able to give us actually some really clear steers about what was a pragmatic solution. There's an interesting paper, which I'm going to pop in the chat, that I was looking at yesterday, because there's one of the concerns is, are we going to get lots of borderline results? Are we going to be making referrals to people who don't really think they're appropriate, and so on? One interesting finding is that if you do BNP measurement, it reduces the need for echoes. So we sometimes send people for echoes before starting clozapine. Actually, if we do some of the blood tests instead, it's likely that we can avoid needing to wait for an echo, and actually that reduces the costs overall. So, I would say that we generally want to reduce the threshold for people asking for specialist help anyway. I think that's part of the point, that historically, one of the reasons that people have died preventably is that perhaps there wasn't an escalation to specialist input previously. But the conversation, again, locally about what access do you have to cardiology, do you have enough of it? How is it arranged? Do your commissioners need to help you, and so on? Those are very much local conversations, and I realise that it's very variable from place to place. But I would say we want people to have a lower threshold for speaking to specialists, and it's quite likely that a lot of those conversations will be very reassuring. But I guess that would be my position on that. Did you have any other thoughts on that, Mal?
No, nothing to add. I think cardiomyopathy is quite tricky to pick up, and I think we were trying to sort of work with the limited evidence on this, and again, to focus more on being able to pick up early clinical signs of cardiomyopathy, which is why, sort of some of the questions in the red flags are quite broad, sort of broad-reaching, but a lot of them do also kind of focus on or try to pick up cardiomyopathy at least, or to try and raise the index of suspicion for that. So fatigue, shortness of breath, ankle swelling, things like this were all put there in with cardiomyopathy in mind as well.
I think we spend quite a lot of time trying to figure that out, and I don't think we necessarily the evidence just didn't help us enough. So a question that we had was, what about cardiomyopathy? And certainly in some of the cases of deaths of people who've been taking clozapine, cardiomyopathy rather than myocarditis has been cited as one of the causes. And Mal's right, there isn't a very clear, there's not a test you can do that will pick up cardiomyopathy early. When you get your ECG changes, that's probably one of the ways you'll do it, but also clinical symptoms. So I guess what we're trying to do here is make people more likely to think about, is this early cardiomyopathy, and should we be doing further cardiac investigations around it? But it's in order to prevent people from presenting when they're really, really quite sick with cardiomyopathy and heart failure later on. So that was an interesting exercise in trying to work out what we wanted to say about that. And as I say, we've probably got as far as we could in terms of the evidence.
Great, thank you. I think the next question is about sort of workforce skills and responsibilities. So I know in the protocol we talk about sort of doing physical examinations, interpretation of results, ordering tests. Who do you see, or what guidance can you give about responsibilities for doing those and interpreting the results of them?
It's a good question because I guess doctors are trained to do physical exams, but lots of other people aren't. What I would say is that a physical exam is one of the best ways of picking up deteriorating health early, because that's the way you're going to see if someone is developing swollen ankles or is developing signs that might indicate something, something like cardiomyopathy or something similar. And we do need to be able to do this on a regular basis on somebody who's got a long-term serious condition such as schizophrenia and is on a long-term medication like clozapine. We do need to be able to do a thorough physical assessment of people to look for signs of, things that we're not picking up in our blood tests, for example. Now, whether that's done by a doctor working in your service or whether there's somebody else who has that skill set in your service, if you're lucky enough to work in a hospital setting or to have resident doctors who have fairly recent experience of acute medicine, that's often what you do. But if you don't have access to that, I would say it's important to think about, might you escalate to the person's GP? So if you notice something about a person that has changed or is concerning to you, should you be actually engaging with the person's GP so that they can have a physical checkup there? I would be of the view that people should be seeing a doctor at least once a year if they have a long-term condition like schizophrenia. And actually, there are really not very many regular touch points with healthcare for our patients. There are people with severe mental illness who don't see a doctor year on year, and I think that might be, a bit of an issue in terms of actually proactively managing people's health. So I think, as with other things, if you don't have a way of doing it within your service and you don't have people who you could train to do it, think about what your alternative would be. And I would say thinking about escalating things to GPs at an early stage so that you can make sure that if you see something you're not sure about, someone will be able to have a look at it for you.
Great, thank you. I don't know, Mal, do you have anything you want to add about that?
No, I think just to add about, so Ed has mentioned about responsibility, but I think there have been some comments about what is the minimum standard. And I think, this is a guideline, and what works on the ground will be different, and that's why we've intentionally not sort of been prescriptive about how things are going to happen. And if someone is and exactly, this has to be person-centered, and how do we facilitate someone's blood tests? How do we facilitate people who are needlephobic having blood tests? This should be, and to go back to the protocol, this should be something that is thought about in the preparation phases of starting someone on clozapine, or should also be part of someone's care as well, to think about the logistics and to think about, some places will suggest putting local anesthetic cream, some places will be okay with finger prick testing. What's the calibration of that with the local labs and things like that? So there's a lot of sort of perhaps more sort of innovative technology stuff that we haven't mentioned intentionally, because resources and availability and uptake will differ in regions as well. So just to be adaptive and adaptable in situations like that.
Thank you. Do you think the fact that we've not been so prescriptive could lead to potential inequalities in implementation, e.g., the fact that those who are in rural areas who've got worse access to care, it then becomes self-perpetuating that they're going to get less of the care and less of the full WIMS protocol completed?
I would hope not. I would hope I would hope that this actually drives up the minimum standard that people are getting. I accept the fact that logistics and resources vary, but I would also very much encourage people to make the argument that these resources are really, really important and that we need to have them. And the savings that you make on someone being stable on clozapine rather than in and out of hospital, and the quality of their life and actually of their physical health that you will get as a result of that, more than makes up for the resource implications. Those are really difficult conversations to have with commissioners, by the way, because no one can see past the end of the financial year. But I think as I said earlier, I would encourage people to actually have discussions around resource if there are really significant gaps. Inevitably, you'll have a different experience of care if you're living in a rural setting as compared with an urban setting, just because services are set up in different ways. But that shouldn't be a reason that people don't get what they need in terms of their healthcare. I think that's really important to highlight.
Great. Okay. I think we covered about physical examination, we covered about BMP, routine clozapine plasma monitoring. I don't think we've covered much about that. What do we think about that? Are we only doing it in specific circumstances or all the time on regular basis?
Mal, do you want to say something about that? And I can come in.
Yeah, so the kind of time point we suggest is annually, after someone's been on clozapine for a year, and subsequently annually as well. And I can't remember what we put in terms of titration. So there are points where we suggest doing it during titration as well, to see if we've reached the target range. And of course, if someone has had a significant dose change or has had side effects, then it's worth doing it as well. The other thing we have suggested, and is when we recognize it's difficult to do, so I work in liaison psychiatry, and this is very difficult to do, is if someone is unwell, physically unwell, if someone has infection, to try and do a level as well to help to guide things. But in terms of the kind of like time points in which we could predictably routinely do levels, we are suggesting once a year.
I think we had I just have a memorable point in the development was I think in a previous draft we put something about abnormal clozapine levels, and someone kindly pointed out that every clozapine level apart from 0 is abnormal because you don't normally have it in your body. But I think one of the things from the prevention of future death evidence and previous cases is that abnormal levels were involved in really quite a lot of them high levels, and there's a lot of things that make your clozapine level vary. Smoking is the biggest one, but it's not the only one. So we really, really wanted to make sure that people had a low index of suspicion for an abnormal, an outside range clozapine level in a way they might not previously. it does make sense to do it at least annually to check that nothing else has changed in it, because as people age, all sorts of other things about how your body metabolizes drugs and so on can also change. So really you need to be able to keep track of whether there's a trend in a particular direction, but actually you should primarily be clinically led and treat the actual patient and what they're presenting with rather than just the number.
Great, thank you. How does this how does WIM sit against people's current local guidance and policies that they might have? What should be going on regarding discussions of WIM versus that?
It's designed to inform it, really. So some places have really brilliant, robust guidelines and policies. Whether they're being followed is another question. But my advice would be to, if you have an existing protocol guide, look at it against WIM's protocol, do a gap analysis, see where the gaps are. There might be no gaps, which is brilliant. Carry on and enjoy your day. But if there are gaps, that could be something that informs your next version of your guidance. But it doesn't replace it. It's designed to support it and help you to form it.
Thank you. I think that makes that quite clear. If we go to the red flag side of things, so obviously there's quite a lot in the red flags, aren't there? And I suppose if we're thinking about having to go through all of those in each clozapine clinic appointment, that might expand the amount of time that's needed. How do you recommend people should be using the red flags?
I suppose the way I would see it, and the way we conceived the red flags part of the protocol, is that going on clozapine is a learning process. So when you've never heard of it, there's loads of stuff you don't know. When you've been on it for 5 years, you will know most things about it. And what the red flags list is supposed to do is not provide a script that you go through slavishly every time you have a conversation, although you might do that to begin with, but for people to become really familiar with these things as symptoms to look out for, so that, you know, in someone who's really familiar with clozapine, you could say, have you had? They said, no, haven't had any of those symptoms, don't worry. You know, the conversation could become a lot shorter. Bear in mind, a lot of people with treatment-resistant psychosis don't necessarily volunteer a lot of information, and you might, and it's really important to ask specific questions so that they can tell you yes or no. So there is quite a lot of benefit in being able to do that for some people, but it's designed to be a sort of learning tool so that people become very familiar with this, and it almost becomes second nature as part of your regular clozapine discussion, so that people can know that actually I haven't opened my bowels for a really long time, and that's unusual, is something that they would potentially volunteer.
Great, thank you. I think I was sort of coming towards the end of the questions that I've got, but I suppose your thoughts on, do you think this is a minimum standard? Is it a best practice, or is it a long-term aspiration project?
If we got to, I suppose we've used the term minimum standard, but the reality is places are not going to be able to implement this all from day one. And actually, as we learn more about implementation, we might find that some standards are just not really realistic, and we can change them in future iterations. What we would really want to see in the longer term is a driving up of the standards generally across the country, so that they become more consistent, and people, families, patients can just feel more assured that they are getting the right monitoring wherever they are in their journey and wherever they are geographically. So that would be so I guess it's aspirational, but hoping becomes minimum in the future, if you see what I mean.
Great. Okay. I think this is kind of my last question. I wonder whether, Mao, you might, future developments of the protocol, where do you think we go next with this?
So Ed's alluded to this as well about sort of clozapine in specific groups. So I think the clear need is also in older people, because and then we've talked also about clozapine in pregnancy, perhaps and Parkinson's, for example, other indications of clozapine. So yeah, I think there's a lot of directions this could go. Clozapine in young people as well. Now that there's also increasing interest and research into use in young people, but also with the improvement of this version as well. With implement, as Ed has said, with implementation and seeing what works and what doesn't work, and with the additional monitoring that, let's say, POMH are doing for clozapine standards as well. So yes, I think it could go everywhere. There have been some comments about splitting this into a patient-facing version and a clinician-facing version. I think that's something that we did think about. We've thought about other sort of output, almost like a clozapine passport, but we never didn't manage to get to it. But yes, like whatever can make this better, whatever can make this more accessible and more implementable, would be very welcome. And I guess, Ed, I did wonder about this as well. You know, where does the protocol sit in terms of who decides when it needs to be updated? That, you know, where I guess questions are coming to you at the moment as well. But yeah, for ideas and questions about future iterations.
That may be partly a question for Jo, because I think this network is one way that we'll get that feedback. It lives in the college somewhere, and actually slightly deliberately, it doesn't sit under a specific faculty or committee. So I'm holding on to it at the moment, and I'm keen to see where it would best sit in the longer term, because is it continuing professional development? Sort of, not really. Is it something else? You know, so it's sitting with me as an ex-college person and the policy team, who are brilliant, and will be carrying on fielding queries about it. But I guess the only other thing that I was going to mention was the MHRA, because I think there were some questions about the medicines regulator. So we have been engaging with them. They've been working proactively with us. They're very supportive, and my understanding is they may decide to signpost to the protocol, but the protocol is not regulations. They are the regulators. They're responsible for how the medicine is licensed. But just to give some assurance that we've been working alongside them, among many others.
Great, thank you. I mean, I suppose the feedback and the future developments come from the people who are using it, don't they? And receiving the feedback from patients and carers and staff as well. So that guides our future developments with where this goes next. I think that's come to the end of the questions that I had. I don't know, Mao and Ed, if there was anything that you want to elaborate on any further.
Before we do that, what I was going to say is we've got 2 minutes. I'm happy to stay on, but it depends on like you guys. We're recording this anyway, so if anyone has to go, we can do that. And one of the other things I was going to just pick up on and say, maybe we could come back and do like an update to this in a few months' time, where people can then report on. So maybe we could work out an appropriate time point to do something like that, so people can then say, right, we've been living with this for however many months. This is what we're facing right now.
That'd be amazing. That would be, you know, I just think, you know, the value of a network like this is enormous in trying to drive this kind of improvement. So I would be very happy to come back if people can bear to listen to me banging on for an hour.
In the chat, guys, give me a rough indication of time difference so we can work with Ed and Claire on an appropriate time point. So what would be useful for you in terms of living with this, to be able to know that you've got something to report back? We could always do a survey as well. You know, we could always implement some sort of survey as well.
And certainly things we haven't got to in the chat, very happy to have those sent to me, and we can use that for doing an doing an FAQs. So anything that people have put in, I'm happy to have sent across to me. So really pleased to have everyone's participation and interest. I'm slightly blown away by the response, and it's absolutely what we wanted. So just thank you from me.
Okay, so I think 6 months. So we're looking at the end of this year then. End of this year or beginning of next. We'll have a chat about that and see if we can come to a conclusion.
Fabulous.
Thank you. So if anyone's feeling brave, you can turn on your cameras and we'll give them a little round of applause, because if this was in person, we would be doing that right now. For those of you that are not as technically challenged as me, you can find the right button and press react, and we'll just say thank you very much for coming along to do this today, and we do appreciate it. I'm going to do the old-fashioned clap. So is Lauren. Thanks, Lauren, but that's just because you're my friend. Everyone else is like really trendy and doing the whole virtual clap that I can never find. So thank you to you for coming as well. I really appreciate it. I'm being blown away by the number of people that have not only signed up but have attended today. It obviously shows that there is a strong need for this kind of session. So if you have other things that you'd like me to cover, get in touch with me, and part of my job then is to find someone to deliver that content for you. I don't sit inside your head. I'm not a practicing clinician. I'm a chartered psychologist with a special interest in this area. So if you tell me what you would like to know, especially if it's in relation to physical health and a very broad inclusion within severe mental illness, then I will more than happily try and find somebody to do that for you. I believe we might have someone with a hand up. Are we okay to take a question? Because I'm aware we're 1 minute past and we're beyond that. Is that all right?
Yeah, go for it.
Kathy, do you want to ask your question? Whilst you're coming online, I'm going to summarize the whole chat, send it over to Ed, Claire and Mao with an update. So it's all going to be, I'm going to get AI to sequence it for me into sections, and they will then hopefully, don't open. I'm very open about how I use AI. And they will hopefully then incorporate that into some FAQs for you as well. So thank you very much for turning up and for hanging on.